I'm going to record.
Great. Well,
Okay, great. Okay, so
go ahead.
Just one sec, Becky. That's okay. I was just gonna welcome everyone.
I'm sorry.
That's okay. So my name's Amy Harris. I'm the manager of the PCPCH program. And I just want to welcome everyone today to this webinar. And I'm going to turn it over to my colleagues to share with you about PCPCH Standard 1G alternative access.
Okay, now my turn. Good afternoon, everyone. My name is Becky Velasco, and I'm a verification specialist for the Patient-Centered Primary Care Home Program.
Good afternoon, everybody. My name is Amber Anderson, and I'm an improvement specialist with the program.
Thanks so much for joining us for our webinar on PCPCH Standard 1G today. You can go to the next slide. Before we get started, let's go ahead and go over a few webinar logistics and Zoom etiquette reminders. This webinar will be recorded and uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Amy Harris for help. If you feel comfortable, please have your camera on and put your name and organization info up. And please feel free to put questions in the chat as we are presenting. Any questions or comments you submit will be answered during the question and answer session at the end. Here's the agenda for today's webinar. We'll start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we'll deep dive into PCPCH Standard 1G. Next, we'll share additional PCPCH resources and upcoming webinars. And last, we'll have some time to take your questions.
Yeah, hopefully it'll be quick. Thank you. Bye.
The Patient-Centered Primary Care Home Program was established in 2009 by the Oregon Legislature as part of the state's broader health system transformation strategy to improve access to care, reduce cost for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address inequities in their patients' population. All practices applying or reapplying for PCPCH recognition after January 1st of 2025 must meet these new standards. For more information, I would encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is available on our website. Next slide. So today I'm going to review PCPCH Standard 1G. PCPCH Standard 1G is in core attribute number 1, access to care, which from the patient's perspective means healthcare team, be there when we need you. The intent of Standard 1G is that all patients should have the same opportunity to access their provider or care team. Some patients face barriers with traditional office visits. Practices that offer telehealth or alternative visit types are extending services to patients that may not receive care if only given the option of a traditional in-office visit. Practices can also improve access to care for their wider community by offering primary care services in a local community setting. Next slide. Standard 1G is a check all that apply measure. That means you may attest to all of the measures that best describe your practice's activities. There are 3 measures in Standard 1G. The first measure is 1G1. PCPCH offers telehealth services to its patients in their primary language. This measure is worth 5 points. The next measure is 1G2. PCPCH offers telehealth services, PCPCH offers at least one alternative visit type to its patients and can demonstrate that it's improving access. This measure is worth 10 points. The third measure is measure 1G3. PCPCH regularly provides patient care in community-based settings. This measure is worth 15 points. Measure 1G1 is new, and measures 1G2 and 1G3 have been revised. Now Becky is going to start us on a deep dive into each of these three measures. If you have questions as we go along, again, please feel free to drop those in the chat and we'll address those at the end of the presentation.
Great. So first off, just want to note that the current measure 1G1 under the 2020 standards is being moved to standard 1E in the 2025 standards. So now let's take a closer look at the new measure 1G1. A practice is meeting measure 1G1 if it offers its patients telehealth visits as an alternative to traditional in-office visits. Telehealth visits must be offered to patients in their preferred location, include at least 10 to 15 minutes of medical decision-making, and adhere to the following criteria. The patient agrees to telehealth service terms, privacy policy, and charge for receiving a telehealth visit from a physician or other licensed provider. Second, communication must occur over a HIPAA-compliant online connection. Third, the treating provider appropriately documents the telehealth visit, including all pertinent communication related to the encounter in the patient's medical record. Fourth, if the treating provider is not the patient's PCP, they forward a summary of the telehealth visit to the patient's PCP and communicate with the PCP as necessary. Additionally, the practice must make interpreter services available during telehealth appointments to patients with primary languages other than English. Interpretation services do not need to include video to meet this measure, but must, at a minimum, include some sort of audio interpretation. Here are a couple of examples of activities that demonstrate successful implementation of measure 1G1. A practice has a patient population that sometimes experiences barriers in making it to the clinic location. For example, travel expenses, caretaking responsibilities, incompatible working hours, etc. To improve access to their services, the practice offers telehealth appointments for conditions that can be performed virtually without a reduction in quality of care. The practice makes its patients aware of this option via their scheduling team and offers interpretation services during these visits to patients with primary languages other than English. A practice is located in a rural area and has patients that often need to travel 30 minutes or more to reach the practice address. They offer their patients telehealth appointments at their location of choice. Though they don't have many patients with primary languages other than English, they still ensure that the telehealth technologies they contract with include interpretive services that staff know how to use them should the need arise. As you're completing your PCPCH application, we strongly recommend you gather and save all documentation that would be needed for a site visit. At a site visit, you will be required to provide documentation to the PCPCH program to demonstrate you are meeting the measures you attested to. For measure 1G1, you would need to provide an example of a chart note from a telehealth appointment conducted in the patient's primary language. Patient information must be removed from those notes in accordance with HIPAA.
Thank you, Becky. Now let's review measure 1G2 in more detail. A practice is meeting 1G2 if it regularly delivers care to its established patients in at least one way that is an alternative to traditional in-office visits and improves access to care. Alternative visits must contain medical decision-making and be relevant to the unique needs of the practice's patient population. They must also be offered on an ongoing basis, though the exact frequency can vary based on the type and patient need. A practice can leverage organization-wide resources to meet this measure so long as practice staff are directly involved in delivering the care. There are two alternative visit types relevant to 1G2. The first is a visit conducted in alternative locations, such as the patient's home or current place of residence, skilled nursing facility, independent care facility, rehab center, senior home, or other community setting. Care can be provided at these alternative locations from a mobile van or directly on site, but again, it must include medical decision-making. The second type is a group visit or patient education classes with individual assessments and services. These visits involve multiple patients at once and can sometimes take the form of a workshop or class that is facilitated by a provider or qualified healthcare professional. Group visits can either be on site, virtual, or in a community setting, but must include that individual patient assessment and medical decision-making to qualify as an alternative visit type. Classes or workshops that do not involve medical decision-making are considered self-management support rather than alternative visit types. Please note that telehealth is not an alternative visit option that will meet this measure 1G2, as that is covered under measure 1G1. Next slide, please. So a couple examples of activities that demonstrate successful implementation of measure 1G2. A practice starts a diabetes education group class for its patients once a month. In the evening, that is facilitated by a nutritionist. Following the class, a physician offers one-on-one medical decision-making for each group participant. Survey results indicate that these classes are improving access to care for these patients. The second example, after receiving feedback from a patient family advisory council, a practice finds that home or skilled nursing visits best meet the needs of their patient population. They have two providers that offer in-home or skilled nursing facility visits on a regular basis. Appointments are listed as such on the schedule or in the chart as an alternative visit type or a home/skilled nursing facility visit. At a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate that you're meeting measure 1G2. The first is examples from a chart note or that shows an alternative visit type. And the second is evidence that that alternative visit type is improving access to care for your patients, your practice's unique patient population. For example, evidence that alternative visits are being utilized by patients on a regular basis, survey results, feedback from your patient advisory council, comment cards, etc.
Thanks, Amber. Now let's go ahead and take a look at the third and final measure in the standard, measure 1G3. A practice is meeting measure 1G3 if it provides healthcare services to residents in an external community setting, regardless of their patient status. Community settings may include schools, libraries, clubs, shelters, fire departments, agricultural work sites, communal events, or other settings that local community residents frequent. Healthcare services can include screenings, preventive services, tests, treatments, or other forms of medical care. Practices may choose to provide care at community settings from mobile vans or directly on site. The practice can partner with external entities and larger organizations to meet this measure, so long as practice staff are among those providing care. Here are a couple of examples of activities that demonstrate compliance with measure 1G3. Each year, a practice hosts a back-to-school health fair for students at their local K-12 schools, during which practice staff provide well child checks, sports physicals, and immunizations for students on a first-come, first-served basis. The practice charges a flat $10 fee for students that are not registered patients to cover event costs while ensuring that the services are still financially accessible to the average family. A practice sets up a quarterly community outreach booth at various community events in which staff provide reproductive health counseling, oral birth control prescriptions, condoms, and rapid STI testing. Staff assist interested non-patients in filling out registration paperwork with the practice. If you're ever unsure whether an alternative location activity falls under 1G2 or 1G3, a good guideline to follow is that 1G2 activities are intended to be additional options for established patients, while activities for 1G3 must be available to non-patients as well. And at a PCPCH site visit, to show compliance with Measure 1G3, you would need to provide a description of the community-based care events, including the community location, types of services offered, the practice staff involved, and how often they occur.
The PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the standards. Webinars are scheduled every other Friday through December. You can find a complete list of topics and registration information on our website. The next 3 webinars are listed here on the slide. I'll hope you'll be able to join us, but webinars will be recorded and posted on our website if you can't make it. Next slide. Thank you. This final slide is additional resources that you may find helpful. The first is our PCPCH program website. The second is the 2025 TA guide with detailed information about how to implement every measure and the documentation requirements. Next is a link to our TA resource webpage. And finally, the community engagement report and evaluation. Lastly, you're always welcome to reach out to the PCPCH program with any questions through our program email as well.
Great. Thank you, Amber and Becky, for that overview of the new standard or the revised standard. So now we're going to open it up to your questions or comments or feedback, anything that you'd like to discuss. If you have implemented some of these strategies already, we'd also love to hear about that as well. So it looks like we have one person asking to post the link to the recordings. Yes, we will do that. And then it looks like we have a question. Actually, Rachel, would you mind taking down the slide so that we can see folks? That would be great. So here's a question in the chat. It says, we do preventative dental care in the schools for all students. Oops, my chat just moved when you stopped sharing. Okay, we do preventative dental care in the schools for all students. It's our organization's staff, but not practice-specific staff. So guessing that wouldn't count. Does it need to be primary care, or could dental prevention type services be options? So for 1G3. So they're not offering primary care services, they're offering dental services in schools. We actually haven't had that question come up before. I'm curious what our site visit team would think about that.
And they may know us well. We have a preventive, like the one real strong place where we provide service to non-patients currently is really through that dental prevention program, which primarily is dental hygienists that work specifically in that program versus being practice staff functioning in that program. But we also have integrated oral health at 2 of our clinics that do similar preventive care. So I'm just kind of thinking a little bit thinking out loud of how we might feature a test.
Yeah, and then thinking about how that might intersect with our oral health standard as well, because we have a standard around oral health integration. So that's
we don't have a dentist has been our big hang up on the oral health stuff, but Yeah.
I think you can use an advanced nurse practitioner for that one, or not nurse practitioner, but an advanced dental hygienist can also make that too. So that's a great question. I think we actually need to go back as a team and talk about whether we would accept oral health services only for this particular standard. The intent, as we said at the beginning, is really about offering primary care services that would take the place of an office visit, which could potentially include, community-based settings as well. And because we focus on really like those primary care office visits, we'd have to really talk about whether whether we would also include dental services, particularly if you're offering dental or oral health services in your practice. If you have integrated oral health, and these are maybe patients that wouldn't ordinarily come in for an oral health visit into your practice, but then you're offering it in the community instead. That might be an area where we would consider like, yeah, that would make a lot of sense. But if you're not offering any oral health services in your practice and you're just, partnering with somebody to do oral health services in the community, then probably not, because it's not really replacing an office visit. But we'd have to go back to as a team and talk about that. So that's a really great question. We can provide you specifically with some clarification around that, and then also just make that information available in our site visit TA guide potentially as well. So that's a great question.
Yeah, not super urgent. We have
but still, that's really good, and it's also really helpful for our learning as well, for us to think about those, because that's not something that I thought about, or that our team thought about. You can see the nodding. We're like, yeah, that's great. So, good. So thank you for that question. It looks like, okay, another question. For 1G2, can you elaborate on what practice staff are directly involved with the delivery of care means for a clinic leveraging organization-wide resources as described in the TA guide? For example, would a centralized team who supports clinics by providing in-home visits for patients who can't make it to the clinic meet this measure? So and that comes from Robin Jensen. So a centralized organization, so a large system, a health system. If a health system has a group of providers that provide in-home visits, but they aren't necessarily tied to a specific practice, it would just be a group of providers and all they do is in-home visits and they serve all the patients in that health system, would that meet 1G2? I think that's the question that's being asked. That's a good question. I think we would want to see maybe what the connection was to that patient with that the provider is seeing, kind of what that connection is. Is that person their regular provider? Is it somebody that they're seeing on a regular basis? We probably would need some more information about how that's structured in order to say for sure. It could potentially meet the measure, but I think we need some more information about how it's structured. So I don't know if that's something that this is already implemented or something an organization is considering implementing, but I think we need some more information about how that's structured. I'm looking at our site visit staff. If you have anything to add, Amber or Becky, or
yeah, I was just going to add, I think we see a lot of times where there's clinics centrally located and maybe they have a care coordinator, LSCW, or some staff like that where they do share amongst maybe 3 locations, 2 locations. And I think that if that person is already serving your patient population and that person is going into their home or some other facility to do those visits, then that centrally located staff member who's already working in that clinic in some capacity, that kind of centralized staff, I think would qualify for this type of appointment. I think I agree with with Amy. If you have 4 clinics and one provider from one of those clinics does house calls for all 4 of those clinics, but they never see the patient in any other circumstance, I would agree with Amy that we would need some more information on how that would connect.
Good. Anything else to add or from our team? Okay. Okay. So I hope that's helpful. So maybe we can get some additional clarification if that is coming up for your practice or some additional context. Let's see. Okay, it looks like Kimber is maybe commenting. We continue to see dental prevention / fluoride / first tooth, et cetera, being pushed into primary care. So it sounds like maybe, making an additional, not argument, but additional context for the oral health services that might be happening within primary care. So. Okay, so here's another question for 1G2. Is it permissible to have individual follow-up in a clinic visit after the group forum? Not sure how it plays out to meet with each individual after the group session is finished. So that was an example that we had written in the TA guide. I think it certainly, there certainly does need to be some follow-up. I guess I would defer to the site visit team to see if that follow-up could happen like a follow-up visit, or if it would have to happen like actually at the meeting in order to qualify.
I think the intent was for it to happen at the meeting because again, this is an alternative location to coming into the clinic. So if they have to wait to schedule an appointment for a follow-up and make it back into clinic when that was their barrier in the first place of having this alternative location or group class, I think that's kind of not what we're looking for in the intent of this measure. It's for them to be able to access their care in an alternative format, whether it's a group visit or a telehealth visit, or excuse me, a home visit for 1G2. And it would be the same, like if they had a home visit, you wouldn't wait for them to come back to the clinic for a follow-up. I know it's a kind of different scenario, but I think the intent of the measure is for them to be able to get that individualized assessment during the group session.
Yeah, and I'd just like to build on that. Just as an example, if there's a family that, like in a rural area, that scheduling individual appointments for every single family member is a barrier, like having to travel at separate times and coordinate all of that. And then being able to offer that groups or families can come in at the same time, even if it's at the clinic location, allowing them to receive that assessment at the same time in a group setting, or just in the same like appointment or day, that's one thing that can help improve access for those groups or communities where scheduling one at a time is just kind of a barrier.
Good. Does that answer the question? Anything to add? Okay. Okay, so let's see. So the next question is, can you elaborate on why an annual community vaccine clinic would not meet this measure? This is for 1G3. How could this example be modified to meet the measure? So the reason that the vaccine clinic only doing community-based vaccines doesn't meet this measure is because vaccine clinics are pretty widely out in the community, and people can get vaccines in a lot of different places, not just primary care. Many people get vaccines in pharmacies, they get vaccines at their workplace, they get vaccines sometimes at the primary care office, but there are a lot of opportunities to get vaccines out in the community that aren't necessarily tied directly to a primary care visit. So just doing a vaccine clinic alone is not enough to meet the intent of this measure, because it really is about providing those services that, again, we talked about at the beginning, would be happening only in primary care. So it's to take the place of an office visit. The way that this measure could be modified is if you were offering a vaccine clinic in partnership with something else. So you're offering a vaccine clinic and some other type of service that would really be unique to just something that would happen within your practice, or not your practice, but within primary care. Something else that wasn't readily available out also in other places within the community would be a way to do a vaccine clinic and something else. So I don't know if folks have anything to add to that. Anyone on our team? Okay, great. Okay, so next question. So we have an addiction specialist that is a family nurse practitioner who goes out to our community parks on Thursday with a local nonprofit and provides PCP type services to the unhoused in the park. They work from a van, but since the family nurse practitioner isn't technically our PCPCH provider, would that still count? Okay, so it's an addiction specialist that goes into the park, provides primary care services, work from a van. I would think yes. I mean, even though that person isn't technically meeting, they aren't technically your primary care provider in the practice. They're still working in your practice. They're focusing on addiction medicine and they're providing primary care services. I think we would want to see what those services were that were being provided. Is it just addiction medicine type services, or are they providing actual like other types of primary care services? But I would think that yes, we would. That sounds to me like it would count, and it sounds like a great way to provide that care in the community, actually. So that's a good question. I don't know if anyone on the team has anything to add. Okay. So for 1G2, what are the specifications for a group leader to have? So what are the specifications for a group leader to have when discussing behavioral health modifications for patients? Is a master's in counseling permissible? I'm not sure I understand what that question, I'm not sure I understand what you're asking.
You do have a list
the
of,
group-
in our relevant definitions for this measure, what we consider qualified healthcare professional for this particular measure.
Oh, that could be what this
I think
person.
that might be what they're asking. So
Mhm.
that is in the new specifications. Page 31 has those relevant definitions for this particular measure. But it is a physician, an MD, DO, ND, physician's assistant, nurse or nurse practitioner, FNP, RN, behavioral health provider, PhD, Psych D, LCSW, LPC, LMFT, care coordinator, pharmacist, traditional healthcare worker, registered dietitian, or nutritionist.
Good. And then it looks like that person has an additional question as well, but related to 1G3, which is, does participating at a community outreach booth once a year meet the standard? Our clinic hasn't been involved before and played a wellness game, discussed what our clinics provide to people walking by. So I would encourage you to take a look at the specifications. You do need to be providing some type of medical service, some type of service. It can't just be games. It can't just be promoting the practice. That's really more of a marketing event or more of a community engagement event. It does need to actually be offering some type of care. So I would just encourage you to take a look at the specifications for that. So let's see. Clarifying question for 1G2. Do you need to offer both alternative locations and group visits or patient education classes? So no, you don't need to offer both. You can offer one or the other. Yep, that's a good question. Oh, and then Robin says, thank you. Okay, so I think I'm just scrolling back through the chat to see if I missed anything. I definitely will put the link in, or we'll put the link in. Are there other questions that people have that you want to put in the chat about this standard?
Those are really great questions.
Mm-hmm. It sounds like there's already some really great work going on around this standard. I mean, the practice that's having the nurse practitioner go out in the community and provide services to people who are unhoused, that's great. already doing, I think, doing those type of community booths are really a great way to not only promote your practice, but if you could also think about what kind of services you could offer as well at that time, that would help this, or that would help you to meet this measure, as well as doing something great to promote your practice and provide some community awareness. So it sounds like a lot of folks are doing some of this work, or you're already on the right track, to be doing it, to meet the measure, if you want to go for that. Let me just see. And we'll definitely talk more internally about the oral health services and whether that were offered elsewhere. Maybe for a practice that has integrated oral health, would we consider that?
Looks like there's another question in the chat from Amanda. Brand new to PCPCH, does a clinic have to meet all three? And just going back to kind of basics, since you're new to us, the only measures that are required are our must-pass measures, and none of these are must-pass measures. So these are all optional. You don't have to attest to any of them if it's not anything you're doing in your clinic, or because it's a check all that apply, you could choose all three if all three apply to work being done in your clinic. And Jordan's right. The more you meet, the more measures you meet, the more points you get. And the tier levels are all point based, so you don't have to get to the 255 points that Jordan mentioned. You can have less points than that if you'd like, and still test these measures or not.
Yeah, I would encourage you, Amanda, to just take a look at the technical assistance guide that we put a link in the chat. The first couple pages before you get into the specifications for each standard really go over which measures are required, which ones are optional, how the scoring works, all that stuff. And if you have any questions about that, not just Amanda, but anyone on this call, you can always contact our program. Rachel, who's on our call today, she answers all of our emails and does a great job at really helping practices as they're attesting or applying for recognition. And then if you have, of course, measure specific questions, if Rachel can't answer them, then she reaches out to the rest of the team. To somebody who would know. So. Okay, well, I don't see any additional questions in the chat. So I just want to thank everyone for coming today. And also to let you know that you can reach out to us at any time. Just as I mentioned, if you have specific questions about the TA guide or these standards, that's fine, but anything. If you have questions about any of the measures, any help with your application, definitely feel free to reach out to us. If there's something that occurs to you after you hop off today, and you want to send us a follow-up question, we're happy to do that. Anytime. We're definitely here for you and helping you understand and implement the standards. Oh, it looks like I see a couple more questions coming in. Was the age? Okay, so it looks like I can answer this question quickly. Our next attestation is due on 10/27. You would contact the email inbox about that. So Rachel, so that is on the slide. It's just our PCPCH email. So what is the age limitation for vaccines delivered in a pharmacy setting compared to the ACIP schedules to assist in determining if they're a good alternative for immunization completeness? I'm not sure. I don't know. I don't know if anybody on this call knows what those are. Okay, great. Infants can't get immunizations. Yeah, that's true. Great. Thank you for that. Yes, over 10 or 11. Yeah, I seem to remember that from my own teenager when she was younger. So I remember not being able to take her to the pharmacy for some of those things, like her Okay. Okay, well, thank you everyone again. Enjoy your weekend. And a recording of this will be available online. And I will also send out a link to where that recording is. So perfect. Okay, thank you. Thank you so much. Have a great weekend.